Good afternoon, everyone. It's my pleasure to present today's speaker, Trish Williams, who's going to talk about consent, confidentiality, and data safety monitoring. Trish Winter is our Human Subjects Research and Ethics Education Manager, Carilion Clinic. She got her BS from Elizabethtown College and a Master's of Music Therapy from Temple University, and then went on to get a PhD. So in addition to being our Human Subjects Research and Ethics Education Manager, she also is a music therapist. So I look forward to her presentation today. Thank you, Trish.
Thank you, Dr. Farrell. Thanks for coming, everybody. We're going to talk about the consent process, confidentiality, and data safety monitoring. If you have any questions, feel free to pop them in the chat or let me know. I probably can't see you if you raise your hand, but you could just pop on and interrupt and ask any questions that you might have. So today we're going to recognize that consenting participants is a process. It includes a consent form, but it's much bigger than just the consent form. We're going to identify potential threats to confidentiality, and we're going to develop a strategy for data safety monitoring for your research project. Then we'll apply best practices when drafting your IRB application. So first, I have a polling question. Who in attendance has consented participants for research? There we go. Who is consented participants? And then after you answer that, when we get as we get the results, pop in the chat some challenges that you've noticed in the consent process. What's challenging about obtaining participant consent?
All right, it looks like we have everybody that is going to answer, so we'll end the poll.
Oh, great. Lots of people with experience with consent. I'll be interested to hear about your experiences. I am a clinical researcher. I have consented both individuals who can consent for themselves and also individuals who require a legally authorized representative, such as a caregiver or parental permission. So people who cannot consent for themselves. And I can tell you, it's a very big job to do the consent process. So as you have a chance to pop some stuff in the chat. Again, informed consent is a process, and I'm going to say this about 30 billion times in this presentation. It's not just the form. It's not just a single episode. It is an ongoing conversation. When you obtain informed consent, you're getting authorization based on a person's understanding of what's going to happen to them. Consent is legal, it's regulatory, and it's an ethical requirement in healthcare and in most research with human subjects. And it is one aspect of conducting ethical clinical research. So you're all familiar with the Belmont report. Consent really falls in the foundation of respect for persons and autonomous decision-making. Consent process has to be an autonomous process. It has to include both the conversation that you have and the document, and then making sure that the individual's authorization or their refusal for enrollment is articulated. It, of course, ensures autonomy, but it must address potential vulnerabilities. And we're going to talk about vulnerabilities outlined by the federal government, but also other kinds of vulnerabilities that we come across. Informed consent should be truly informed, and it has to assure that a person has the capacity to consent to research, which can also be tricky. And the consent process should be two-way communication between the person consenting and the person who is being asked to participate in the research study. Click. My forward is having a problem. Okay, the Carilion IRB has templates online for the consent form, but we have just updated our consent form. So we will be updating the templates. If you are in process of submitting an IRB application that includes consent, you might want to contact the IRB so you get the most up-to-date consent form for your submission. And then the new consent form will be going up on the IRB website. Hopefully it is easier to use, a more seamless process. Please note that the IRB wants to make your job easier, not harder. So if there's a task or a process that's particularly challenging and we can do something about it, then please contact us. We would like to adapt the process for ease of use. There are required elements that must be in all consent forms as required by OHARP and by the FDA. If you use our templates, and please do, all of these requirements are in the consent template and they kind of guide you how to answer and what you need to say. But you have to tell people that this is a research study. You have to tell them the purpose, how long they're going to be involved, describe any procedures, and identify which of the procedures are experimental and which procedures might be standard of care, so that they can differentiate what's going to happen if I just show up versus what's going to happen if I show up and agree to participate in your research study. What are potential risks or discomforts, and what are potential benefits to subjects? And is the benefit for me directly, or is the benefit for society at large? Is there an alternative that might be appropriate to participating in the study? And what is the extent of confidentiality? The world is changing rapidly. NIH is now going to be rolling out on the 25th of January a data sharing plan, and that will make us reconsider where data goes and what data goes and how other researchers use data. And our intent, of course, is always to keep that information confidential, but we have to let people know what's going to happen to that information. For more than minimal risk studies, will I get compensation if I'm injured? Or will there be a medical treatment if I get injured? Who do I contact to answer questions? And a statement that participation is voluntary. Now, there are also additional elements of informed consent that are not requirements, but these are also in our consent form template. So what are the risks to the participant, embryo, or fetus if the participant is or may become pregnant? What is the researcher going to do to assure the safety of individuals who are of childbearing age and to protect them and their fetuses? How or when a person's participation may be terminated without their consent. If I stop showing up for your research sessions, are you going to terminate me from the study? Is it going to cost me anything extra to do this? How I can terminate participation in this study, but the PI has to let people know if there are risks. So if a person is enrolled into a drug trial and they're taking the experimental drug and it is having some impact, and if they stop taking it, what could potentially happen because of early termination? How will significant new findings be shared? If you collect my biospecimens today and 15 years from now, you find out something about whatever it was you were looking for, are you going to look back 15 years and contact me and let me know? Or do I not get to know what happens in the future? And then how many people are going to be involved in the study in terms of subject enrollment? We do have an e-consent process. It's through the REDCap system. Subjects can sign electronically by typing their name and date or using a finger or mouse. You have to request that in the IRB application, and it must be approved by the IRB consent process. You can consent participants remotely or in the clinic via computer, cell phone, or tablet. If you are doing it remotely, you have to have some plan for identifying and verifying that that person is the person that they say they are. If you're planning on a research study where you're going to be using e-consent, please feel free to reach out to us early on, and we're happy to help walk you through that process. So again, that is the consent form, and we're going to talk about the consent process. So step 1, providing the information, disclosing risks and benefits, discussion with the potential participant, and checking the comprehension, making sure it is a voluntary decision to participate or not, and then the authorization of consent. How do we present the consent form? Well, be really sensitive to where you're conducting the process. Are you in a busy location? Is there a private place you can go to? How do you assure that other people aren't overhearing that someone is being enrolled in a study? and making sure that the participant or legally authorized representative feels like they're in a secure location. This is the start of a relationship based on clear and open communication. Please always provide the participant with the written consent form and give the participant as much time as possible to review the consent form before deciding whether or not to participate. And as much time as possible, it could be very variable for research studies, from 30 minutes to 5 days, 7 days. Just as long as you're explaining that to the IRB so that we can understand how much time people have. Explain the research and take your time and allow for ample opportunities to ask questions or voice concerns. So what I know about research at Carilion is that it's very complicated. There are a lot of moving parts, and it's not easy for people with a lot of health literacy to understand. If we're considering people who may not have that much health literacy, are we giving them enough time to really think through what's going to happen in this study? The person obtaining consent must review each section of the consent with the potential subject in detail. So when I was a wee researcher learning about how to do consent, my mentor said, oh, just hit the high spots, go right through it. That was bad advice. I should never have been told that. At Carilion, we want people to read through each section in detail. This is not something that you gloss over. It's not just hitting the high spots. Answer questions, but also ask questions to facilitate, future questions, that kind of thing. We have some examples of questions for the consent process. You can ask them to describe in their own words, what's the purpose, explain to you what you'll have to do if you're in the study, tell you some other options, ask if there's anything else they'd like to know, ask them if they recognize the benefits and the risks, how long they're required to be in the study, where will it take place, if they're going to receive the investigational drug or device or intervention, or if you're in the study, and who do you contact if you have questions or you experience side effects once the study begins. Comprehension is a tricky thing. There are a lot of reasons why people can look like they understand and not really fully comprehend at the level that they might need to. So this is also an ongoing process. We have to consider factors that might impact someone's ability to understand. If you're in the emergency department and you're getting consented in a study, this might be the worst day of your life. That is a factor that could impact participating or understanding. If you are in palliative care unit and you've learned some distressing news, that's a really hard time to process what's going on. It's not a reason to not do research, but it's part of how researchers show empathy to research participants. How are we going to assess understanding? And how much do potential participants understand? How much should they understand? And what happens or should happen when a participant does not understand? We recommend a teach-back method at Carilion. It's not just Carilion. Lots of IRBs use this, but it's really asking the potential participant to tell you in their own words what this study is and what's going to happen. That we would use open, non-shaming questions, that we're not going to ask a lot of closed-ended questions, yes or no. And we're going to emphasize that the responsibility for understanding is on us, the researcher, and not on the potential participant. So if you don't get it, then it's my job as the PI to make sure that you do. If they're not able to teach back correctly, then go back through and explain again and recheck. So we talked about potential barriers to understanding and comprehension. The relationship between the person conducting the consent process and the patient. Who is this person to the patient? Is this their beloved general practitioner who they have trusted forever and is asking them to be in a research study? And of course, they want to do whatever that person asks. They believe that that person has their best interest in mind. The person's age, their cognitive capacity, their health literacy. How familiar are they with research? What is their level of education and their ability to read? their social cultural values, their language of origin, the environment or the timing of the discussion, anxiety and fear, pain, what medications are they on, or have they come in and they're under the influence of a substance? The quality of information that the PI discloses about the study, readability of informed consent, and embarrassment around asking questions or for clarification. So we talked about these. I want to highlight the different kinds of misunderstandings, that there can be misconceptions, there can be misestimations, and there can be optimism from the potential participant about the impact of this research study on their health and wellness. Also, research participants may be in a fine line between knowledge versus appreciation. So if you walked into my hospital room and you brought forth a really well-designed study, I would definitely be appreciative of the art and science. That does not mean I understand what you're talking about. It just means that I appreciate this whole idea of research and medicine and doing something good for society. We also want to talk about therapeutic misconceptions. Participants believe that their medical needs will determine their assignment to a treatment group. So if it's a randomized controlled trial and one of them, the arms is a placebo and one of the arms is the treatment, a person will believe or could believe that they will be assigned to the treatment group because they need the treatment group, and that they won't be assigned to the control group. Or that the participant believes the PI is going to modify the protocol to serve their particular medical needs. Or that the PI is not going to administer a treatment that might cause harm. They're only going to offer an intervention that's going to help. Participants might also have unreasonable expectations about the likelihood of benefit from study participation. If this is the last resort for a potential cure or a way to solve a healthcare problem, you might want to believe that this is the thing that's going to make all the difference. All right, so it's time for a question. I hope you're still all awake out there. Which of the following populations are considered to be vulnerable by the federal government? Children, prisoners, pregnant women, human fetuses and neonates, people with diminished mental capacity, all of the above, and none of the above.
Couple more answers coming in. Okay, that looks like everybody. Oh, there's one more. All right, we'll end the poll.
Oh, all right. I got mine. I got my answer right. Yay. I'm not seeing all the results, but my assumption is that it was a pretty accurate.
It was 100%.
Oh, good. You're also good. Right. So these are the people that the federal government says we need to provide extra protections for. And IRB offices have people that they can call in as experts at any time, but especially when we're talking about doing research with these potentially vulnerable or vulnerable populations. Oop. Let's see if I can make Zoom work. No. Why isn't it going forward? Let's see here. It's all good until it's not good anymore.
Check where your mouse is. There you go.
There we go. All right. So the IRB has to approve enrollment of vulnerable populations, and special protections may be needed for these individuals. But special protections might also be needed for people that the federal government does not identify as a vulnerable population. And that includes non-English speakers, students, your students, especially employees, your direct reports, or educationally or economically disadvantaged individuals. So in these cases, OHARP, Health and Human Services, recommends that the IRB really pay attention to coercion, undue influence, and put additional safeguards in to protect the rights and welfare of these participants, especially when it comes to any kind of compensation. Is the compensation reasonable? Is it too much? Would it possibly be a point of coercion? And that there is some vagueness, there's a lot of vagueness in a lot of the OHARP regulations, and that's by design. But IRBs are really digging into these studies to make sure that these people are protected. But there are additional vulnerabilities that we want to be cognizant of when we are potentially recruiting someone into a research study. So are they under the influence of a substance? Are they in active withdrawal? Or do they have any comorbid psychiatric disorders? Are they highly distressed, frightened, or overwhelmed? Are they experiencing fluctuating capacity? Do they have language barriers? Is this intervention or treatment the last possible option for treatment? Are they deferring to an authority figure? It could be an authority figure in the room in the case of abuse of a spousal relationship, or it could be the doctor as an authority figure and the doctor-patient relationship, the promise of payment or receipt of free healthcare services, and any social vulnerabilities such as distrust for an organization for individuals who have experienced discrimination within that organization. So we don't have a ton of studies that come through where non-English speaking participants are being recruited. It's definitely an area of improvement overall. The IRB office is working to have a fully translated consent in the Spanish language. Right now, we do have a translated short form. There is a very specific process when consenting non-English speaking participants. So you have to present the consent information in language that is understandable to the subject. And for those who do not speak English, they need a consent document written in a language understandable to them. And so that can be challenging given the amount of languages that might need to be considered. And also when a document is translated, it must be certified by a specific certification organization to assure that it's saying what needs to be said. If there's an occasional unanticipated non-English speaking subject, an alternative short form method is allowed. But the IRB needs to be informed, and if there are additional possibilities of non-English speaking participants, then that has to be approved by the IRB. So check in, please. Ideally, best practice would be to say if there's a high likelihood that we will have an occasional non-English speaker, and we would like to be prepared for that if it happens. And then there are really specific requirements for signing and who signs for non-English speaking consent. Again, if you're going to be recruiting non-English speakers, please reach out to the IRB and we can provide additional support. But you have to have a translator. You have to have the translator sign. They can serve as a witness. The person who's being consented signed, or their legally authorized representative. And then if there's a research coordinator, PI, of course, they're signing as well. So there's additional signature requirements for non-English speaking consent. Decision-making capacity for research. This is really tricky, like I said. So I do work with people, I do research with people who have decision-making capacity issues. But these individuals can present really, really well. And it can be very hard to tell if they're understanding or not. People are really good at sort of having the social wherewithal to not look like they don't understand. So when we are doing an assessment for decision-making capacity, we want to make sure that we're getting verification from a physician and we're doing what we need to do. But we want to make sure that individuals understand the information, they understand the risks and benefits, and they can appreciate how the risks and benefits are going to impact them personally. that the individual has the reasoning to incorporate information with their personal priorities, their values, and the potential consequences and alternatives, and that they can express a choice in a consistent fashion. If we have to employ a legally authorized representative, please note that Virginia has very specific laws regarding who may serve as a legally authorized representative, and there is a hierarchy of who first, who second. Obtain permission, consent from the LAR. If you're going to have LAR studies, you have to go through the IRB and get approval for that. There are lots of additional questions that pop out in PRISM regarding use of an LAR. An individual or judicial body authorized under applicable law who is able to consent on behalf of a prospective subject. And it's believed that the LAR is going to do what the participant would do if they were able to consent for themselves. That's what we hope. Ultimately, we want to make sure participants are capable of making this decision voluntarily, that there is no coercion or undue influence. And if there is an LAR, that the LAR's decision is an accurate reflection of the wishes of the participant. Is the LAR the person whom the participant wishes to make the decision for them? And what stressors or burdens is the LAR dealing with that might impact their decision-making capacity? I just read a really interesting study where the researchers compared two groups of older adults regarding, one group was the participant group and one group was the LAR group. And they presented the studies to both groups and they separated them. And the LAR group was making a decision about whether that other person would want to participate in research. And when they came back together, they found that the LAR and the research subject did not see eye to eye. And often the LAR was more likely to enroll someone in a research study than the actual person was, especially when it came to like needle stick or blood draw studies. So it's important to consider, would the person really be interested in participating in this research study? And then of course we want documentation of the consent process. So please make sure you're using the most recently approved consent form. PRISM is its own sort of monster. I'll show you a screen capture of how you can find that in PRISM. But make sure the date at the bottom of the consent form is the most recently approved date. Document the consent process in the research or medical records. And then, make sure that the consent process is happening. You might want to check in and see after every couple consents if everything is signed and dated and then it looks good. When people's studies come in for continuing review, we ask for the last signed consent. So we take a look at that and we align it with the last approved one to make sure that everything is happening as it needs to. So if you're in PRISM and you click on the consent form tab, which is usually up in the left-hand corner when you're facing the screen, there is an approved tab that you can click on. And you'll see that it's a PDF form and it has approved on it. And so that's the one you use. Make sure we void the one that's no longer in play so that it reduces confusion for people. If you have questions about PRISM, please let us know. I know everybody has questions about PRISM, so let us help you with the process. If you're new to doing consent, you can shadow someone or observe when people are being consented. Make sure you have plenty of time. Make sure you're in a private location. Make sure you know what study you're consenting for and what's in the consent form. Assess understanding and be sensitive to any discomfort or anxiety. You might have to stop the consent process and come back and try again. Of course, don't coerce anybody, but make sure you're really thoughtful about the potential for coercion when inviting people to participate in research. All right, keeping people's data safe. Ooh, another question. Good. How much information do I have to give the IRB in my data safety monitoring plan? Just enough to get the job done, a reasonable amount, but I'm not sure every question applies to my study, or all of the information, being mindful of providing a response to every prompt.
Got a couple more answers coming in.
All right.
All right, I think that's everybody.
Oh, I got my answer right. How'd y'all do?
We had 100%.
Yay, you guys are so smart. This is your win for the day. So pat yourselves on the back, feel good. Yeah, for the IRB office, more is more. I don't know of any IRB that tells people to stop giving them information. We're usually begging for more information. So all of the information, providing a response, even if the response is non-applicable, we don't know if you forgot the box or if you really don't have anything to put in the box. So take that question out of our mind and put all of the information in for us. Here we go again. Here we go again, mouse. All right. Data safety monitoring plan. Why are we talking about this? Because I'll tell you why. It's a rhetorical question. Because this is a part of the IRB application that really does jam people up. So I want to be helpful and give people ideas about what to put in the data safety monitoring plan, so that when you get to this section, you can really conceptualize what we're looking for and what are the requirements of OHARP for data safety monitoring. So in order to get IRB approval, this is from the federal regulations, each researcher must address the risk to subject and how they're minimized and how they're reasonable in relation to benefits. That the research plan makes adequate provisions for monitoring the data collected to ensure safety of subjects. So sometimes it's like after 5 subjects have been enrolled and participated in the first arm of the study, we're going to look back and make sure that nothing untoward is happening. When appropriate, there are adequate provisions to protect the privacy of subjects and to maintain the confidentiality of data. So when should a researcher create a data safety monitoring plan? So any research involving human subjects who are enrolled requires data and safety monitoring calibrated to the anticipated risks that are going to emerge in that research. So if your study has no more than minimal risk, it's helpful to create a plan and give some idea of how data safety monitoring is going to happen. Just know that the IRB office may require more from you and or clarification of specific elements for study approval. If the research study is going to have a high expectation rate of morbidity or mortality in the study population, absolutely data safety monitoring plan, and maybe even convening of a data safety monitoring board. When the research involves the use of an experimental device that has the potential for mortality or major morbidity, or when the research involves the administration of an experimental agent that has the potential for mortality or major morbidity. If there are multiple study sites, which is becoming more and more common, as team science is the way to go, and we are seeing researchers who are partnering with all kinds of organizations, and that's really important when we consider where is the data going and who has access to it. If there's a reasonable likelihood that the study could be terminated early due to safety concerns, futility, or a lack of efficacy, is your research plan not working? Has something not really happened that's supposed to? How will we know when that happens? Or how will we know what futility might look like in your study? When the study participants represent a vulnerable population, such as children, the elderly, pregnant women, terminally ill, or those with diminished mental capacity, prisoners, of course. When the IRB determines that a data safety monitoring plan is necessary, or if there's a large study population and the duration is long. So in the data safety monitoring plan, these are the things to consider and the information that we will be looking for when we do our review. So who's going to do this monitoring, and what is their affiliation with Carillion? What is their affiliation to the sponsor? What is their affiliation to the investigator? Is it the primary investigator? That's usually the default. Is it a research coordinator who's going to be following up on parts of the study? So who is doing this monitoring? What is the safety information that's going to be collected and monitored? Please talk about the possibility of serious adverse events and unanticipated problems. Of course, you can't know what unanticipated problems are, but what will you do if there is an unanticipated problem? The frequency of periodicity of review of safety data. When are you going to review? How often? At what time points? Procedures for analyzing and interpreting of the data. So maybe you're going to say, when we've collected enough to be statistically significant, we're going to take a look and see if this study is really meeting the aims. The procedure for review of scientific literature and data from other sources that may inform the safety or conduct of the study. So all of the PIs do a really nice literature review in the IRB application, but is there any emergent literature that you might need to pull back into the study and say, hey, this is now part of what we know about this research endeavor, and we need to consider that in our data safety monitoring. Any condition that will trigger a suspension or termination of the research. What are your stopping rules, if applicable? And any procedures for reporting to the IRB. We ask everybody to put this in the IRB application, that you will report unanticipated events or serious adverse events to the IRB, usually as soon as possible, but no later than within 7 days of the event happening. So just put that in. That will be very helpful. Again, it's usually the primary investigator who monitors. That's a minimum requirement. You could have an internal data safety monitoring board. So it could be a group of co-researchers on your study team. It could be a colleague from a different department, or you could have an external independent board that is convened to monitor the study. All right, so these are the parts and pieces of the data safety monitoring plan. We need to understand how subjects will be kept safe. And we talked about these points. When will you be observing? How often? What are the observation points? What are the stopping rules? When will the IRB be modified? What are the reporting mechanisms? Did something happen where subjects have to be reconsented into the study? Something significantly changed that has changed the way we do the research, and now we have to reconsent participants. So some of the examples of activities that might be monitored in your data safety monitoring plan include very specific parameters. Of course, the frequency of observations, individual responses for monitoring, like principal investigator, study coordinator, safety monitor, any stopping rules, exclusion criteria. Have those exclusion criteria changed? Is there anything that you need to be aware of? Again, study stopping rules. You could stop a participant, and that might be one thing, but you might have to stop the study, which is a completely different thing. And then, of course, your reporting mechanisms. Do you have to report to the FDA, to a sponsor, to a granting agency? Where does the information have to go? And of course, always reporting to the institutional review board. Looking across data integrity, what data points are going to be reviewed in the data safety monitoring plan? How often will they be reviewed, and who will review these elements? You can see there's an ongoing theme here, right? It's like, what is the thing that you're going to look at? Who is the person who's going to look at it, and how often are you going to look at it? So that's subject safety, that's data integrity. I don't want to be too terribly redundant. You get the point, and you will get the slides. And I think if you're sitting down to write the data safety monitoring plan for your study, that you might want to have this open and nearby, so you can say, okay, I'm going to look and see some of the things that we should consider and put into our IRB application. Examples of monitoring activities to ensure subject privacy. Oof, yeah. So under what conditions will a subject be screened, recruited, consented, interviewed, or contacted? Are you using protected health information to recruit subjects? Do you need a waiver of HIPAA authorization for that recruitment information. Who's going to be looking at this information and data? How will we make sure subjects have privacy? And also, how will we understand that all of the processes are done in a way that ensures subject privacy? We talked about and confidentiality of data. A certificate of confidentiality. So if you have NIH funding, you can't, or if you don't, if you have NIH funding, you have to have a certificate of confidentiality, but you do not need to have NIH funding to apply for this. The point of the certificate of confidentiality is to protect people for whose data you are collecting that might put them at risk for civil or criminal liability, or could be damaging to them financially, to their employment status, to their advancement or their reputation. This is ideal. The federal government cannot be compelled to pull this research data to be used in a court of law. That's what's supposed to happen. I've been reading some research about these, and it's still a little dicey. I was just at the Primer conference, which is research and it's a professional research organization. And this was a hot topic of conversation, especially as the federal legislation moves more towards states making determinations about what happens to healthcare information, and that the states could supersede the federal government in whether they will honor a certificate of confidentiality. I think that's something to keep an eye on coming down the pike. They were especially concerned about certificates of confidentiality for women who are or individuals who are pregnant or are of childbearing age, given how states might side on abortion. So something to keep an eye on. So this is in the IRB consent template. If you need, or if you're requesting a certificate of confidentiality, this is already in here. You don't need to add, change, do. It's right here for you. And it also allows that individual to know how far data safety can go for them. And data confidentiality, the individuals at heart have some great information about REDCap and Trinetics and Spark. You can plop that right into the IRB application. We understand that these are secure data systems and that we do the best we can. Please also note that a breach of confidentiality is always a possibility. So it's kind of a given when you do your application. Just write that in. There's always a possibility of a breach of confidentiality, and this is how we're going to protect these records. If you are collaborating with a VTC SOM student, a Radford student, even though we have memorandums of understanding with those organizations, they are still considered external collaborators. They are not considered under the entity of Carilion Clinic. And if you are sharing data with them, that is considered sharing data to an external collaborator. And that needs to be considered as well. And people write, will only access through Carilion Clinic systems, will only access through password protected Carilion servers, that kind of thing. And then who's going to manage your study files? Are there guidelines for monitoring documentation? Is the PI going to sample any study files quarterly or annually after a certain number of participants have completed the trial? The IRB office also does periodic spot checks on study procedures and documentation, just to make sure everything's happening the way the federal regulations require. And then protocol implementation. So who in your study team is going to clarify the roles and responsibilities? Who's doing what, where, when, why, and how? And who's making sure that all of that's happening? Who's going to make sure that all the protocol procedures are being taught to the research team and that everybody's on the same page? Has everybody done their city training requirements? Of course, we check that, but make sure that everybody does. And again, Virginia Tech does give us an assurance that Virginia Tech students have completed their city training. So if your application gets jammed up, it could be that we're waiting to hear back from one of the collaborators about the students. So you can always check in and we'll let you know. Who's going to communicate with the team, who's going to plan meetings, conduct meetings, and who's going to take minutes at those meetings? Is there a plan for meeting every 2 weeks or meeting once a month about research studies? A couple additional things to consider for your data safety monitoring plan. The data safety monitoring section isn't optional. All board studies are required to complete this information and to outline a plan for data safety monitoring. And we need to understand how data safety will be monitored. We need to be inside of your head about this. How data safety will be assured, whether the study is viable, and how data will be handled. The statistical analysis, that is super important. You might not consider it to be so important because maybe it's a pilot study, but it is. It's important for us to understand how data will be analyzed. That helps us understand the feasibility. And it also helps us get a worldview on why you're recruiting the number of subjects that you're recruiting. There's a great team of people, biostatisticians at Carillion, that do a fabulous job at this piece, if that's not your cup of tea. And then if you have questions, please contact us. We are here for you. Look, we are smiley, happy people. We want to be helpful. I can always come and do education specifically for your research team on a topic that is really, pinning you down or you have questions about. We can help you walk through PRISM. We can help answer questions at the beginning of a study about how to answer a particular part of the application. You can say, I'm thinking about this and I'm not sure how I'm going to answer the question about how I'm going to keep data safe. But reach out to us as a resource. The more we communicate, the easier it is for everybody to be on the same page and to ensure that participant safety is at the forefront of everybody's mind. That's really what we're here for, is to keep our participants safe. Yeah, so any questions, comments? I'm going to unshare. Boop. How can I help you? You might have a question. You might not.
I have a question. I'm Dr. Aziz, and I've been involved in multiple researches. And I think one of the struggle us as a physician, as a clinician as well, when you are approaching the patient and especially if it's a new patient to you, I guess if you know the patient for a long time and you build this relationship, they know you. But if you have a new patient being referred to you mainly because you're running this study and the referring physician think this is a patient maybe candidate for the benefit of the patient, and you're trying to reach out to the patient and build this relationship, but you're trying to tell them, or you're trying to prove to them you're on their side and your goal is to get them better. And part of the study is the reason that this is what you're doing. And this drug may help them or may not. And as you mentioned before, that a lot of patients, they assume they're going to be on the treatment arm, or the physician going to tweak a little bit the protocol just to get them on the treatment arm. I think this is the struggle, is just to prove to the patient, despite being in the study or not in the study, you're on their side. You meant to help them. Your goal of conducting those study or those trial is to help the patient. And sometimes this become a little bit difficult because they always think you're trying to consent them just for the sake of the study, and you just don't care about their outcome, or you don't care about their health or this or that. So what are your insights on that, and how we can facilitate that, how we can build this relationship with the patient or the subject in a healthy way, in a patient-physician relationship, despite being part of the study or not being part of the study?
Yeah, that's a great question. And I have a lot of empathy for researchers who are sort of going in cold to engage people in this process of considering whether they want to be research participants. I mean, ultimately, our job as researchers, I'm going to put my researcher hat on here, right? And not, and a little bit of my IRB, but as researchers is to provide the information. You know, I know you don't know me, and this is a study and your physician recommended you, and here are the facts. We want to make sure, of course, that the consent form is written at an understanding that they have, like, as it written at a reading level that they possess. I was just doing some looking at reading levels, and our scientific journals are written at a sophomore level, like 14th grade. The Wall Street Journal is written at an 11th grade level. The Roanoke Times is written at a 9th grade level. And the recommendation is for consent forms to be written between a 5th and 8th grade reading level. If that gives you some idea about how the consent form needs to be able to provide information to people in a way that they can digest the information. And I think, Dr. Aziz, it's probably very challenging to enroll people in a study when they might not get the thing that they think is going to help them get better. I wish I had an answer for that. And I think that's probably 1,000 journal articles about why people do or do not engage in a research study. But I think just being, authentically you, presenting the facts, helping people understand, at the end of the day, it is voluntary. And if they don't want to do it, they don't want to do it. I was just communicating with a researcher who indicated that those types of studies are some of the hardest to enroll people in, are the ones where there is a placebo versus an experimental drug. So I don't think I have any great answers for you. If anybody else wants to pop in and talk about their successes enrolling in a study like that, please do. But I will certainly do my work in looking at, sort of globally how people address that issue. Yeah, Dr. Schluepner?
Yeah, Trish, my advice to Sammy and to any investigator is just total honesty and empathy. And that's because the most important thing when you're enrolling a patient in a study is there be trust. And the way to achieve that, in my opinion, is honesty, empathy, and do you believe that it is in the best interest of the patient to enroll them? And if so, why? And just discussion of that. And that takes time at times, takes a lot of effort.
Yeah, and we all recognize how busy everybody is, right? Like this is, you're in a not so easy job to begin with. And then we're saying consent takes a lot of time, and it does take a lot of time. So that's a really, important consideration to say, I know that I'm going to engage in the consent process and it's not going to be quick at all. Thank you for that question. And thank you for your response, Dr. Schluepner. Anybody else have a question? If you do, will you please email me or call me or send up the bat signal? This is what I'm here for. That's the work that I want to be doing every day. So please help me to be useful to the Carilion organization. I'm sure everybody has all kinds of questions, and it's really exciting to hear your questions and hear about your research. Oh, it's so amazing. Some really great work going on here. So that's all I've got.
Thank you, Trish. You did a fabulous job. Thank you so much.
Thank you. Take care.
Awesome. Have a great day.
You too.
Bye, Trish.
Bye.